they all come? Okay. Hello and welcome to our last session. We're having a panel discussion, the final question and answer. You're going to address whatever questions you've come up with as these meetings have progressed over the weekend. Thank you so much for joining us. My name is Angelica Kapoor-Davis. I'm a thyroid cancer survivor and volunteer for ThyCa. I'm also here with my fellow survivor, Patty Woodbury. There we go. And we're joined today by this distinguished panel, who also, by the way, decided that I should wear the headband. So in case you're wondering why I'm wearing butterflies on my head, it's Dr. Tuttle's fault.
Okay.
Dr. Tuttle is an endocrinologist at Memorial Sloan Kettering Cancer Center in New York. And he is joining us today with Dr. Carrie Lubitz, who's an endocrine surgeon at Harvard Medical School in Newtown, Massachusetts. We also have Dr. Mabel Ryder, an endocrinologist at the Mayo Clinic in Rochester, Minnesota, and Dr. Lori Wirth, a medical oncologist and associate professor of medicine at Massachusetts General Hospital Cancer Center and Harvard Medical School in Boston, Massachusetts. And they told me to keep their bios brief so we can get to all your questions. So take it away, Dr. Tuttle.
Oh, that's awesome. So we encourage put questions either in the question and answer or in the chat. I'll try to get to both, but if you put them in the question and answer, it's a little bit easier for me. And I'm old, so making things easy for me is good. Let's go to our young person, Mabel. The first question is, a patient had a lobectomy and an isthmusectomy, and before surgery, the TSH was around 1. After surgery, they didn't start thyroid hormone pills until the TSH got above 2.5. I love this question. What's special about 2.5, Dr. Ryder? Who made up that number in the last guidelines before you attack me? Go ahead, Mabel.
Yeah, well, thank you for being called the young one on the panel. That's not a distinction I'm earning very much these days, so thank you. Yeah, I don't think there is a really special thing about 2.5. I think primarily for low-risk disease, I think the idea with the updated guidelines was to make sure we're not over-suppressing patients and giving more guidance to allowing TSH to be above the 0.01, especially for low risk or local neck disease. And I think knowing that the TSH, like many hormones, fluctuates over time, we wanted to give more liberal TSH ranges. And because most people are, or not most, many people are electing lobectomy for the privilege of preserving their thyroid function, I think that the more less conservative TSH range is helpful to facilitate that for patients.
Because in most of those low-risk patients, we want to avoid an elevated TSH, right? More than achieving the suppressed. Dr. Lubitz, here's a question about the scar. Some doctor in Boston, okay, so I made that part up. A lobectomy scar at Mass General. They took out one side of my thyroid, but the scar was on the other side of my neck. What the heck was my surgeon doing? So where does the scar normally, and help me with that.
Well, how I'm going to answer that question is how I do it. I had the privilege of doing a year of plastic surgery training in my intern year at Michigan. One of the principles is when people look at you directly, if your scar is symmetrical, just like everything else in your face, or mirrored, for instance, your eyes, your ears, etc., that it's less noticeable to people who are looking at you. That's sort of been shown. So I try to keep my scar as low as possible in the neck so you can cover it up with the crew neck or men with their shirt and tie. And I try to make it exactly the same. I feel where the trachea is and go a couple centimeters on either side in a natural skin crease, which I think is very important. I'm not sure how to answer the question. I'm going to defer answering the direct question. Some people do put them off center. But on the same side, obviously, as the lobe they're taking, not obviously, as the lobe they're taking out, or if they have to extend it. Maybe some of you out there have had a lateral neck dissect, extend it by about another 4 or 5 centimeters to this, along the same skin crease, but out to one side a little bit farther.
Great. Lori, there's a question in here about somebody, papillary cancer, BRAF V600E. Can you have some metastatic lesions that are RAI avid? Can you have other lesions that are not RAI avid? She was trying to figure out, that. Can you speak to refractory versus avid in an average patient?
Sure. So with PTC, I think we generally see all one flavor of responsiveness to RAI. So we tend to not see some lesions, say they're metastatic deposits or some unresectable disease in the neck. We tend not to see some spots take up radioiodine and other spots not take up radioiodine. But I think the question of iodine refractory disease can be very nuanced. The ATA guidelines are fairly straightforward, but the Martinique paper allows for much more nuance. And in some cases, it really needs to be determined on an individual basis.
Yeah, Mabel, there's a couple of questions in here about follow-up. And a couple of these are low to intermediate risk, and they're now 5 or 10 years down the road. What does follow-up look like, assuming they're in remission? Questions about ultrasound, radioactive iodine scanning. What do you say, sort of long-term follow-up in somebody that looks cured, Mabel?
Yeah, so I think, Mike, you led this way on active surveillance or follow-up in response to initial surgery and re-risk stratification. So for a patient who has low-risk disease and who at 3 to 5 years has negative ultrasound, negative thyroid globulin, and their initial thyroid cancer was low risk, then we often will graduate patient to our survivorship program. That's often run by our nurse practitioner with the goal of getting a patient back to their primary care with just annual TSH checks and neck exams. And we eventually, after 3 to 5 years, will often stop doing ultrasounds because, as you showed, Mike, the risk for recurrence in that population is only about 2 to 3% or less. And being conservative and just following by exam and clinically is very reasonable.
Lori, a question about somatic testing and how we use that. This is a poorly differentiated with a combination of a bunch of somatic testing. So can you tell us in general, sort of where you see that somatic testing playing these days?
Yeah, I have been talking a lot about gene testing in advanced thyroid cancer in the last couple of years. And the reason why is because there are now several alterations that can be found in advanced thyroid cancer that are directly druggable with new therapies available, and also may guide treatment decisions for enrollment in clinical trials, for example. So I really think that in all patients with advanced thyroid cancer, those tumors need to have genotyping done to see if there are specific gene alterations that can be drugged with new therapies like pralsetinib or selpercatinib that target RET rearrangements. The different types of cancers have different rates of druggable alterations. But still, every single advanced thyroid cancer really should have genomic testing at this point.
Carrie, what about the role up front of molecular testing on either the nodules or the tumor and helping you? Does it affect what you're doing with surgery or lymph nodes up front, Carrie?
So I mean, I think this is we have this conversation a lot, and I'm sure you do at Memorial. If you can do BRAF testing on an FNA specimen, on a cytology specimen. So without getting too technical, it's about a 99%/100% predictive of it being a papillary thyroid carcinoma, and you don't need to send it for other molecular testing, at least at that point. Lori and I, myself and some others at Ryan Sullivan were looking at actually testing it in the blood. That's still sort of ongoing, but it's another thing that we could potentially use in patients who already had their thyroid out and didn't have BRAF testing at the time. So that's something that hopefully is still being put through for a potential a blood test, which would be great.
Yeah, we'll be looking at. Mabel, here's a good question, a little different topic. The issue is Forteo. Using it for osteoporosis, and they say if you've ever had radiation, we should stay away with it. And the question was, does radioactive iodine 19 years ago count as a type of radiation that would keep you away from Forteo?
That's a good question. I don't use Forteo very often, but I think the data and the black box warning about Forteo and previous radiation exposure has really suggested that the risk for an osteosarcoma or bone cancer is extremely rare or unlikely. So I don't think I would view that exposure as a contraindication for Forteo, especially that long ago.
We agree. Lori, some comments about Herthal cell cancer with extensive angioinvasion. You know, I get to see the easy Herthal cells that are cured, and you never get to see them. You get to see the group there. So your thoughts sort of about Herthal cell and how you treat that in the distant setting?
Well, so Herthal cell thyroid cancers we know are a unique group of tumors unto themselves. We don't think of them as subsets of follicular thyroid cancer any longer, and that's because of the genomic makeup driving the Herthal cells really are unique. That said, we don't to date really have specific Herthal cell targeted therapy that has made it to prime time, but that's okay because Herthal cell thyroid cancers can respond to the standard VEGFR multikinase inhibitors that we have in our arsenal, such as lenvatinib. So we don't necessarily see Herthal cell thyroid cancers responding differently to lenvatinib than other types of iodine refractory advanced DTC.
Can I make a comment?
Yeah, please go ahead.
So the one thing I get asked about frequently from patients who come to my clinic, get their thyroid nodules biopsied, and on the cytology report, it says there were some Herthal cells in there. And I just want to make it clear to everyone out there that just having Herthal cells in and of itself is just a description of a cell, and it doesn't portend necessarily a cancer risk.
Very good.
Can I just add to Carrie's point? So, and then if there are some Herthal cells in a final histology from a lobectomy or thyroidectomy where there is a cancer, that's also not necessarily a Herthal cell carcinoma. So only if there's a certain percentage of Herthal cells present does that cancer get characterized as a Herthal cell carcinoma.
Mabel, there's a couple questions in here and a couple comments about, you know, combination T4 and T3 and some of the impression that we're becoming more open to that as opposed to we never did that before. I mean, you're speaking for the entire thyroid community, but
yeah, exactly.
how about you personally? You've been doing this for a couple of years.
Yeah, so even me personally, I think in my practice, unfortunately, there are patients who suffer after near total thyroidectomy on T4 alone, despite TSH levels being at goal, who suffer from what they view as hypothyroid symptoms, most common of which are fatigue and brain fog and even inability to lose weight. And I think as a group, we've become more open in Rochester to doing T4, T3 combinations, where we come down on the dose of levothyroxine and add a Cytomel prescription once or twice a day. Unfortunately, in my experience, I haven't found that has had a major impact or change in their quality of life. But I tell patients that as long as we get the TSH to goal, whatever that goal is for that particular patient, whether it's on T4 alone or T4, T3 combination, then I'm also happy. And if your quality of life can be better, but with a safe TSH that's not going to be associated with long-term adverse outcomes, then I'm okay with that.
Carrie, there was a couple questions on here, but what do you tell people how to take care of their scar immediately after surgery? Creams, gels, what do you tell them?
Well, I tell them save their money and put their pocketbook back away. There is nothing has been shown in clinical trials. In fact, there was one trial that, again, a plastic surgery journal, they put, I'm not going to say the name of the scar cream, but a scar cream on one half, let's say vitamin E for lack of a better term, and then just regular moisturizer with stock on the other side. And subjectively, you know, having a bunch of plastic surgeons look at which side looked better, they picked the side that didn't have the vitamin E on it. So that was the one trial. I get often asked about Mederma. I think it's called Mederma. The one thing that's not going to harm you are those silicone gel strips, but they still are expensive. I don't think they necessarily help. I think if a scar is well placed, and you aren't prone to having hypertrophic scarring or keloiding. And yes, someone just put in the chat, sunscreen is the most important thing. So most women and men might use facial cream that has both, have some sunblock in it, and that's ideal once the scar is completely healed. I actually tell my patients to buy those little sunblock sticks that we used to use on our kids' faces with, you know, the 45 or whatever, and just every morning just wipe it on your, you know, have it in your purse or your back pocket or whatever. I'm going to stop talking now.
Very good. You're being very politically correct, Carrie. I like that. Lori, let's get Carrie out of this mess. There's a couple questions about liquid biopsies. Carrie touched a little bit on it, but can you tell us what liquid biopsies are? What does that mean? And it seems like people can get them these days. Where are we on that?
Yeah, so liquid biopsies are basically trying to detect circulating tumor DNA from a blood draw. And there are commercial companies that provide liquid biopsies. Some big academic medical centers also do have in-house assays. Many insurance providers will cover liquid biopsies. We are not quite there yet within thyroid cancer to know how reliable these tests are to, say, detect minimal residual disease or to detect increasing circulating tumor DNA levels or decreasing levels when patients are on treatment for thyroid cancer. And for many patients with thyroid cancer, we don't necessarily need circulating tumor DNA to answer those questions because we've got great other tumor markers from blood tests that we can readily take advantage of, thyroglobulin or calcitonin and CEA. So unfortunately, I think in thyroid cancer, we just don't have enough data yet for circulating tumor DNA assays to become part of our standard arsenal for taking care of patients with thyroid cancer. I think we'll get there, but we're just not quite there yet. We need more data.
Carrie, there's a question in here about somebody that had a lobectomy. A 30-year-old had a lobectomy. I want to just trade it off. And after the lobectomy, it turned out to be a 3.1 centimeter papillary cancer and was told that nothing else needed to be done. How do you have that discussion with a patient and decide whether something needs to be? Because 3 centimeters is kind of getting up there.
Yeah. So obviously, I would make sure that there aren't any on ultrasound. Make sure there's nothing in the contralateral lobe. No concerning nodules or lymph nodes in the area, which looks suspicious at all. But the most recent ATA guidelines and my own studying of this through the SEER database show that under 4 centimeters, it is okay to just, and for a classical papillary with nothing else that concerning, to take out just that thyroid lobe. I can tell you in my reality, if it does have a BRAF mutation, I do think of it differently. I'm one of the people in the boat of that BRAF has a higher risk of recurrence, but ultimately there's no difference in survival from taking that tumor out with a thyroid lobe versus a total. And getting back to what Mabel was saying is that the consequences and quality of life changes that occur where people who are definitely on thyroid hormone, maybe not with half out, but we really have to weigh that risk and benefit. So, and I'd say I agree with what he or she was told.
Yeah, it's a discussion when you have to open the door. Mabel, there's a question here about somebody that had a total thyroidectomy, radioactive iodine, and years later, perhaps the usual 4 or 5 years down the road, sees these little nodules in the thyroid bed. And questions about vascularity and not vascularity, or what, they weren't there a couple years ago, they're there now. TG is still undetectable. How do you deal with those when we find those years later? Oh, you're on mute, Mabel. There we go.
Sorry, forgot. Yeah, so we see that actually not infrequently because we have a thyroid cancer triage, and any patient who comes to us with a thyroid cancer, we get an ultrasound. Sometimes they may be coming to us more about symptoms and their thyroid hormone levels, but incidentally, we get the ultrasound, and sometimes I'm looking at the report or the images, and I'm trying to figure out what we need to do. And I often take a conservative approach, to be honest with you, because there are lots of tiny nodules and post-op changes in the neck after surgery, whether it's 1 or 3 or 5 years later. And especially in the era of vaccinations and infections, it's not uncommon to see these. So I like getting serial ultrasounds over time, especially if thyroglobulin is undetectable, and following. And then I think over time we will know whether what's there is something that's clinically needed to be intervened upon or can be followed conservatively.
Yeah, Lori, there's a couple of questions about other cancers and thyroid cancer. It comes up at most of these ThyCa conferences, particularly thyroid and kidney or thyroid and breast. Any thoughts about, I don't know the answer to this, so I'll give it to you. What do you think?
Oh, thanks a lot. I don't know the answer. No. So most thyroid cancers arise just by virtue of the way that the human body was designed, which was less than perfect. And when cells multiply and divide, they have to make copies of all of their chromosomes, or all of that DNA needs to be copied. And there are going to be random errors that occur all of the time. And most of those random errors are either going to be silent or else they'll cause the cell to die. But every once in a while, one of those random errors is going to give rise to a cell that has a survival advantage. And then you have the makings of a cancer cell. So that explains, I think, for the vast majority of thyroid cancers. There are rare familial syndromes like Cowden syndrome or the Dicer-1 syndrome, where there are inherited thyroid cancers seen. But those syndromes really are quite rare, and I don't know of any connection to kidney cancer and thyroid cancer, or to breast cancer and thyroid cancer for that matter. And these are all common cancers. Cancer is a common illness in our human population.
Yeah. Carrie, there's a couple questions on here about people.
Can I make one comment about that? I have to.
Please, so, yes, go ahead, Carrie.
I'm not sure if the question may have also been because melanoma and renal cell carcinoma, I think, were what people were referring to. I did a study looking at 45 years at MGH about secondary tumors that go to the thyroid, which is, we had only 13 cases. We do, thousands every year, and we only had 13 cases over, a 30 or 40 year period where they found a different tumor in the thyroid. So I don't know if that's what people are asking. And 5 of them, of the 13, were renal cell carcinomas that were treated with thyroid lobectomy. A couple of them were melanoma, and a couple of them were lung cancer, but that was more extensive disease. Yeah. So I don't know if that was part of that question.
No, I think so, because we see that usually in the setting of like widespread Mets, it goes to thyroid, but the exception is renal cancer. We've occasionally seen an isolated renal cancer Met years down the road as a single Met to the thyroid. So Carrie, let me ask you a surgical RFA alcohol ablation, drink some alcohol question. Total thyroidectomy many years ago, radioactive iodine now with a 1.3 centimeter, presumably lateral neck metastatic lymph node. Surgery, watch, ethanol. How do you have that discussion?
Wow, that's an easy one. So the board answer is that you do assuming this is a lateral, probably level 3 or 4 lymph node metastasis, and it's biopsy proven. The board answer is you do a modified radical neck dissection, which sounds a little more crazy than it actually is. It's really cleaning out all the lymph nodes along that muscle there, which is it's called the sternocleidomastoid, and all of the lymph nodes underneath that area. The thought being that even if you see one lymph node that's positive, there are probably microscopic cells in the other lymph nodes in the area that you want to get out, so you don't have to go back in the future. We are actually opening. There already is one at Mass Eye and Ear, and we are starting our own radiofrequency ablation clinic through the Mass General Hospital endocrine surgery group, and with our radiologists and other folks. The point being, in other countries, they are using radiofrequency ablation and ethanol ablation for very small recurrences, generally in the thyroid bed, like those ones we were just talking about that, my thyroglobulin is very low, but it's, it has been used for that. We don't have tons of data for that in the United States. And for now, we are only using radiofrequency ablation for benign nodules that have been biopsy proven as benign as for now, but there's more to come for that. And I wouldn't be surprised if there is a clinical trial down the road, maybe by somebody on this call, to look at looking at a direct comparison between just zapping that one node and versus with alcohol ablation, RFA, or doing the whole lymph node dissection. That's a good clinical trial you should do, Dr. Tuttle.
Yep, we're working on that. Mabel, can I have you unmute? You guys have done radiofrequency ablation for lymph nodes and stuff for a while, right? So how have you guys been doing that?
Yeah, we've done quite a bit of alcohol ablation for lymph nodes, and we're now branching into radiofrequency ablation, primarily for benign thyroid nodules, but Maria Stan and Interventional Radiology has a protocol for even small papillary thyroid cancers, and I have one which is 1.2 centimeter primary tumor for which the patient elected radiofrequency ablation. But RFA is a little bit different because they often leave a little bit of rim of normal tissue around it. It's not necessarily ethanol. When we put ethanol in the lymph node, we're expecting that it's going to diffuse throughout the entire little lymph node and the capsule and be more comprehensive. But radiofrequency ablation is not necessarily as comprehensive. And so I think the field is going to evolve and emerge, and we'll see where it ends up. I think for things that are a centimeter and smaller, I think the cost and the efficacy of ethanol ablation, of what Ian Hay has shown, is very effective. And for small isolated nodal metastases, especially in the lateral neck where there's not a lot of worrisome real estate, I think it's an ideal approach, especially if a patient has had comprehensive surgery in the lateral neck. If they've not, then you might be chasing lots of lymph nodes with alcohol, which I'm not sure is the ideal. But I think as we're doing more lobectomies, to be honest now, and finding a few patients with a single or a few lateral lymph nodes, now I'm asking, what do we do with these? Do we go back to surgery? Do you do a completion? Do you just do the lateral? Or can I target them with alcohol? And I actually follow patients over time, because nobody really dies from a lymph node that's followed for 6 to 12 months. And I let the disease declare itself. And if after a year there's only that still isolated lymph node and I haven't seen 5 other crop up, then I'm pretty okay doing a focal ablation approach.
It is kind of amazing. If you look like what we were saying 15 or 20 years ago, we'd have never had this discussion, right? It was not only lateral neck dissection, but everything, all the way from the top to the bottom. Then we went through the central neck. And I think we're starting to appreciate that in the papillary cancers in particular, that you can watch them. On the other hand, we're not watching a lot of tall cells and PET positive. It's a select group that we're watching. Lori, there were 2 or 3 questions.
Can I make one comment about
that
there's no important real estate in the lateral neck? No, I'm half teasing, but if there is, I haven't gone back in a neck that's been alcohol or RFA ablated. If they do blossom, I don't know if your surgeons have commented on how sticky it is over there once that's already been performed. I'd like, if it makes surgery more difficult is my question down the road.
That's definitely a good point. And it does make surgery, our surgeons will say it's a little bit more difficult because it's a little bit more scar tissue. But when I usually, before I send a patient for alcohol, especially if they haven't had the lateral neck dissected, we get our surgeons involved also from the beginning, and we have consultations, and so the patient understands. And if the surgeon says, at worst case, if we have to go back in, I'm willing to go back in and I think it's feasible, then we proceed. If the surgeon says, this is going to be really difficult to go back in if you don't do the treat it now, then we make a decision more towards surgery. So you're absolutely right, Carrie. It's not that it's just there's less critical structures, I think, and there's more time to wait. We're usually not, as endocrinologists are usually not patient kind of people, and especially for the central neck. But for the lateral neck, I just have a whole lot of patience in letting the disease declare itself. So
no, it's a lot more to come in the next, I bet, 10 years. It's all going to change all over again.
Yeah.
Yep.
And I think so. And I think the real key is to have, anytime we're watching or deciding whether to watch something, whether it's central lateral neck, it's always one of the surgeons and one of the endocrinologists. We do that together because we have a different view. I often point out that one of the really important reasons I'm not a surgeon is 3-dimensional anatomy is a challenge to me. So having surgeons help me understand, I usually ask them, if it gets bigger, will it make your surgery harder? And will it invade anything important? If you can answer those 2 questions, I can help talk to the patient. Well, if it gets bigger, is it going to invade anything important? And I think just as importantly, if it got bigger, would it make your surgery harder? And I think the ablation sort of stuff would go in that same arena, right?
And I think good ultrasounds, I am blessed with very high skilled, high resolution, good sonography. And unfortunately, many of patients that come to Mayo for a second opinion or seeking alcohol ablation, when we do that lymph node, that ultrasound, we find not just 1, but often 4 or 5 suspicious lymph nodes. And it's just not, most of the patients, when I first got to Mayo, that we pre-scheduled alcohol ablation and we tried to make their appointments efficient, we ended up canceling because surgery was the best approach. And so I think the access to really good high resolution ultrasound, not just once, but over time, really helps understand the scope of the disease and the trajectory and what the best approach is.
Yeah, I agree, Mabel. We see the same thing in people referred to us for active surveillance, right? And probably at least, and I'm probably their 3rd or 4th opinion, and still about 10% of them clearly have ultrasound findings that it wouldn't be appropriate. Hey, Lori, take a couple minutes. There's lots of questions about medullary and RET inhibitors and what's next after selpercatinib and pralsetinib. I mean, it was so exciting to see those drugs the last few years. What's on the horizon coming up, Lori?
Well, so unfortunately, we do know that both selpercatinib and pralsetinib, that patients can ultimately develop acquired resistance with both of those therapies, with medullary thyroid cancer and also non-small cell lung cancer. So what do you do after that? So fortunately, there are a couple of drugs that are in the pipeline. The Turning Point Therapeutics has a drug called TPX-0046 that's in the first in human setting right now. It's still in the dose escalation phase, so it's still early days for TPX-0046, and I think it's too early to know how well it's going to work, but it's a really nifty drug design. And then the Loxo group at Lilly has been working for a number of years on their second generation RET inhibitor designed to overcome the acquired resistance that can emerge on selpercatinib and pralsetinib. That agent, I believe, is going to be going into the first in human studies very soon. So I think they knew early on to expect the emergence of acquired resistance based on what we know in other oncology settings, such as in non-small cell lung cancer, when patients are treated who have ALK rearrangements and then they're treated with ALK inhibitors, for example. In fact, selpercatinib and pralsetinib are already designed from the get-go to overcome the most common expected acquired resistance at the gatekeeper RET V804, and they work at that site. So they were already like second generation RET inhibitors to begin with. So we're well ahead of where we would have been 10 years ago in terms of the second generation drugs coming into the pipeline.
Lori, let me let you keep going for just a minute, because there's a really great question that starts, scared to ask, but is there a study approaching patients that have had a great response to, say, systemic therapy and either lower the dose or take them off? So stopping, discontinuation trials. I hear you guys talk about this sometime, but where are we on that now, Lori?
Yeah, so there isn't any such study that is underway. And I really think that in general, it's less of an issue with a drug like selpercatinib or pralsetinib that works so well and is in general very well tolerated. The drugs do cause side effects, and occasionally the therapy does even need to be discontinued due to treatment-related adverse events, but that's with selpercatinib, that's just in 2% of patients. So really the drugs are very well tolerated. So the need or the interest to study that question is less than with some other drugs that cause more toxicity. I think the question is can these drugs cure the cancer? And then if so, then you should be able to stop it at some point. We are seeing complete responses to these therapies, and we are seeing some patients with complete radiographic responses as well as biochemical responses, meaning that the calcitonin and CEA levels go down to normal levels and stay there. So I think there will be some anecdotal information coming out at some point in the future about what happens with those patients that are in complete response that for whatever reason stop the therapies. But it would certainly make me nervous to stop a drug that is working well, that's relatively well tolerated, without knowing that the cancer is not going to come back.
Yeah, these are great. This is why I love to be the moderator and not the person answering these questions, because for all you guys that are listening, when we're on panels and our peers ask us questions, they know what we know and don't know, and they're generally nice enough not to ask us what we don't know. That you guys apparently don't care. So here we go. What about this one? I want to hear all three of you answer this one. Okay. What are your thoughts about a patient recording their office visit? Carrie.
Frequently, because we were talking about this earlier about that there's a lot of FaceTime because they weren't allowed to have visitors with them during the meeting. I asked that they don't publish it on public media or any platform. But other than that, I think sometimes patients have difficulty retaining all of the information that we give them during an office visit. I think that's been shown actually in studies about memory. So I don't have a problem with it. I don't get asked that often, but I don't have a problem with it. And I just ask them not to publish it anywhere.
Mabel?
Yeah, I think I'm the same. I think I try to go back and forth, and I'm not in a big social platform, but I just ask that they not publish it because things can be taken out of context. But sometimes patients are often recording it, even just my voice, so that they can go back and take notes. And although my consultations try to be comprehensive with my notes, as we get busier and busier, I know they're not sufficient, and it doesn't cover the conversation well enough. And so if it is a tool that helps the patients for a audio recording, I don't have a problem with it.
And Lori, any different for you?
No, and I would just say that, I think that we've all gotten used to the new era where all of the patient's medical record is available to them, including our notes that we generate from our visit, as it should be. These are the patient's lives, and it's not owned by Mass General Hospital. And my words that I share with them during the visit are, I feel is their property as well. So I don't have any problem with it.
Good. A couple of questions in here, Mabel. When do you tell somebody they're in remission or excellent response? Can you be in remission with a little teeny non-specific lymph node? I mean, do you even use the word remission? I mean, we were taught never to use that, and I break that rule all the time.
All the time. Yeah.
How do you do that?
It's a good, I often use it, no evidence of disease. And that's, I think, what commonly my notes are. And what that means is that I can't detect it by thyroglobulin, and that the ultrasound doesn't, while it may have non-specific nodes, there's nothing that's clearly suspicious. And so often on follow-up at year 1, 2, 3, 4, and beyond, I'll say, you're doing excellent, and I don't see any evidence of disease. And I think that is what patients want to know. Do I have cancer? Do I not have cancer? But I always tell them, now that you're 3 or 4 out, I'm going to graduate you. You're likely going to continue to do excellent, but there may be 2 to 3% chance it'll come back, but it's very treatable.
That's awesome. So if I'm your patient, I say, dude, read your note. I mean, Dr. Dude, read your note. Cool. Am I cured?
Yeah, we hate to use the C word, don't we? Because we will be the ones who, they'll come back in. So yeah, I don't ever say cured very often, even in my low risk patients. I just say you're going to do excellent, and I think your prognosis is excellent. And I really will then segue into talking about low carb diets, low sugar, and exercise, and excellent outcomes.
Fair enough. Dr. Lubitz,
I have to say, I'm taking notes here.
I love that.
Ask my patients not to put my recording on any social media, and segue into healthy lifestyle discussions.
Yes,
I love it.
Exactly.
I'm losing control. I remember when she was afraid of me, not so much anymore. Dr. Lubitz, surgeons are supposed to cure people. Do you use the cure word? Do you use the remission word? What do you use?
I think Mabel and I will run a good practice together. I frequently, first of all, I say that, we cleared out all, I do, if I feel confident that we cleared out, I'm honest with someone. If I felt like there was, something about the tumor, I get to, fortunately, I have a pathology report to guide my conversation following surgery. I usually also use the term no evidence of disease. One of our endocrinologists says that thyroglobulin never killed anybody, right? So a thyroglobulin of 0.2, 0.3, and you have a little tiny nodule right where it might be a parathyroid there, it might be a little lymph node, it might be scar tissue, it might be a clip. There are so many little things that could be 3 millimeters or smaller. So I say, you're going to live a long, healthy life. And then I switch into, I switch into healthy lifestyle choices. But no, I think that's I don't use that word.
Yeah. So I don't either. I use no evidence of disease as well. Hey, Lori, a couple of questions here about when you're on targeted therapies. They didn't specify which one, but having to lower the dose because of side effects, does that make it more likely for the tumor to mutate or other mutations to show? What's your feel about sort of striking that balance?
Yeah, so, I think that's always a worry, but we don't, but we don't see that happening. I think it goes to how we come up with a recommended phase 2 dose in oncology phase 1 studies. And so in the phase 1 studies, we give a little bit at the first dose level, see how people do, and increase the dose levels until we get to a dose that's not tolerable. And then usually we back down one dose level and pick that as the dose level. And a vast majority of the oncology phase 1 studies are done that way. And what that means is that we're giving most people a really big dose, and that it's probably well beyond the effective dose that's necessary. But we give as much as possible to be on the safe side, because it's really hard to figure out, can we give a little bit less and is it still going to work as well? So when you have to do dose reductions for adverse events, that's baked into the system. And usually we know that people are still on a really good, healthy, big dose. I can speak specifically with the selpercatinib trial because I know the data so well, but we did modeling based on drug blood levels in terms of how much drug needed to be given to block the RET kinase. And the recommended phase 2 dose is way higher than the amount of drug that's needed to really shut down the RET kinase activity altogether. And so if you do have to do a dose reduction, even the next dose level below is still well above that inhibitory concentration. So it's okay when you have to be on a lower dose because of side effects.
Now, to the audience, panelists have often accused me of making up questions, but this one is now my favorite one. Can you discuss the benefits of low carb and low sugar diets for medullary cancer patients? I didn't make that one up. We're just going to let that one go because I don't know that we have an answer for that one. And I'll go to Carrie.
Actually, Mike, can I answer? Let me say something about that, because that we get that question all the time. That's a really good question. Probably, 80% of my patients ask those questions. And so the problem, what I believe is that the problem with dietary approaches to cancer is that the cancer cells need the same micronutrients, same building blocks, same vitamins, same carbohydrates that the rest of our cells need for our body to be healthy. And so cancer cells feed off of sugar, but so does your brain. Your brain can only use sugar for its fuel source. So unfortunately, our cancer cells are just like our normal cells in terms of the nutrients that they need to be able to grow and thrive. And so unfortunately, I think that there isn't really a great diet that can eliminate the nutrients going to the cancer cells that the rest of your body doesn't need in order to be able to do well. And I think that a healthy lifestyle and a healthy diet really does matter. There's data that has shown that, but you can't have a diet that eliminates things that your cancer cells need that the rest of your body doesn't need. Sorry.
I was actually listening to your answer and I quit reading the questions. That makes perfect sense. There's a couple questions in here about parathyroids and surgery. So Carrie, can you talk a little bit about likelihood of damaging parathyroids with surgery? And then Mabel, how you do that follow-up for the first few weeks or months in the parathyroids? Carrie.
I actually follow my own patients for any symptoms.
Okay.
But most of the endocrinologists I know, at least for the first few months, do. It depends on who's doing the surgery. So the first thing that's important is, just like with the RFA and with everything else, ethanol ablation, it is user dependent, and having experience is important, critical. And so, the usual, what I quote patients is a temporary, it depends on the extent of surgery as well. So if you're doing a big lymph node dissection, either in the central neck and or the lateral neck, you put those, at least the inferior, each of us have 4 parathyroid glands, 2 superior, which are located deeper in the neck, but the 2 inferior glands, which are located a little bit closer to the front of the neck, are frequently involved if there is lymph node involvement. So when you do that, if anyone has had a central lymph node dissection, it puts those inferior parathyroids at greater risk, and the superior ones. On par, if no lymph node metastasis and standard total thyroidectomy. By the way, you can't get hypoparathyroidism from a lobectomy, which is one of the benefits. assuming you have 4 parathyroids, because you're leaving the 2 alone. I quote about a 10% risk of having some temporary hypoparathyroidism, which causes low calcium and the numbness and tingling around the mouth or fingertips, and much less than a 1% chance of it being permanent. So that would, we sort of arbitrarily choose 6 months to mean whether or not it's permanent. I'm not sure where that number came from. It seems like, you know, someone said it once, maybe it was you, Mike, and then it just kept on going. But
it is the kind of thing I would make up. There's no question about that. But, yeah. Mabel, follow on there.
Yeah, and I think Carrie and I would practice together well because we're blessed here with our endocrine and ENT surgeons, and they follow the patients post-operatively. They have an algorithm for hypoparathyroidism that they follow, and by the time a patient sees me, maybe 2 months even after, they're basically on a stable dose of calcium and calcitriol, if that's where what they've needed to do, and then we sort of work from there and do a gradual taper to see if we can taper. We measure parathyroid hormone levels and sort of gauge it. But fortunately, because we have high volume surgeons just like Carrie, the risk of permanent hypoparathyroidism is quite low. So it's managed pretty well here because of our high volume practice.
Switch a little bit here, Carrie. Somebody was told they had a sticky thyroid, and
I saw that question. I wanted that question.
Okay, you got it.
So I love that question. Because do you hear us saying sticky? So there's sticky thyroid, and then there's cancer, right? So the first thing you need to know the difference between is sticky thyroid, and the number one sticky thyroid is Hashimoto's thyroiditis. And so the hardest surgery, and maybe the reason we keep trying to avoid doing surgery for patients with Hashimoto's, even though there's been, anyway, they're inflamed and they're not invading any structures. They're sticky. That's the best term for them. Graves' disease is also a different ball game, very hypervascular, but not sticky. And that is differentiated from, and you can tell what a Hashimoto's lymph node looks like. It's enlarged and round, but it has a very particular characteristic when you're looking visually at it. It's got a pink pearl color versus looking more like a cancer node. So knowing those things going in, when I see a patient that I happen to be doing a thyroid cancer operation for, but I know they have Hashimoto's, I plan for it to be a little bit longer of a case, just a little bit.
Those are awesome. Lori, let me come back to you. It's going to be a hard question because there's so much you don't know about the case, but say somebody's on dabrafenib for monotherapy, presumably a BRAF tumor. It worked for a while and now it stops working. What's your sort of algorithm going forward? Lymphatinib, MEK inhibitor, Pimbro, Lenvima? Sort of how do you think about that, Lori?
Well, yeah, so let's assume that this is an iodine refractory advanced papillary thyroid cancer that has a BRAF V600E mutation. That's the most common mutation that we see in papillary thyroid cancer, whether it's advanced and iodine refractory or not. In general, I would go to lenvatinib as a second-line drug if dabrafenib was the first-line drug, because we know that lenvatinib has great activity in iodine refractory differentiated thyroid cancer, whether there is a BRAF mutation there or not. So if on the other hand, this was a case where a patient was on lenvatinib first and then may have progressed or was then switched to a dabrafenib, then a second-line VEGFR multikinase inhibitor would be quite reasonable. Cabozantinib was just approved for the second-line or third-line setting for radioiodine refractory DTC. And there were plenty of patients in that study that had BRAF V600E mutations as well. There are new agents that are being studied that target the BRAF mutation and the MAP kinase pathway. And so Lilly, for example, has a next generation drug in clinical trials. And so a clinical trial could be an interesting alternative as well.
Yeah, Mabel, this is a question I get a lot. I think it's a good question. How's it possible to have cancer in lymph nodes, presumably papillary, if there was no invasion to blood vessels and the thyroid margins are negative, how did it get to the lymph nodes?
Yeah, it's a good question because papillary seems to love lymph nodes, and we tend to think that it's spread through the lymph nodes through the lymphatic system, which is different than when we talk about the blood supply and that sort of hematogenous spread to the lungs and the bones. But to be honest with you, I don't think we have any evidence or proof of how that actually happens. But presumably it's through lymphatics. But because most people who develop lymph node metastasis don't have distant disease, we think it is a different mode of spread than it is for the ones that get to the lungs and the bones. So that's how I think about it.
So, Carrie, there's a question in here about somebody had a lateral neck dissection and the smile still being off. It's at the very bottom. Can you tell us why that might happen and what the natural history of that might be? Oh, you're on mute, Carrie. Almost
made it through the whole session without.
There you go.
I'm sorry. A smile. I'm sorry.
Yeah. So they had a left lateral neck dissection, and it says still having some effects of my smile being.
Oh, okay, gotcha. So potentially, I assume I'm just gonna. There are a bunch of. Speaking of that lateral neck, there are a bunch of nerves over there. So the nerve we worry about in the central neck, as everyone on this call knows, is the recurrent laryngeal nerve, which is the energy to your vocal fold on each side, which are both muscles within your windpipe. In the lateral neck, there are a number of other nerves, one of which is the vagus nerve, which becomes the recurrent laryngeal nerve. But you have a bunch of other nerves, your accessory nerve, which is the nerve that raises your shoulders. There is a nerve that regulates the movement of your tongue. And there is one nerve, which is the marginal mandibular nerve, which is a branch of the facial nerve, which is up here, that means someone did a really good lymph node dissection if they were up that high, which I actually try to. That is something we worry about during surgery, and that can sometimes cause a little difficulty with the muscularis angularis. I think it's I forgot the actual muscle, but the muscularis on that side, and it can cause the asymmetry. But most of the time, those do resolve over time. So nerves, we say, regrow at 1 millimeter a day, so it can take a long time.
This one, I love this question. This is for you, Mabel. If you had Hashimoto's prior to a total thyroidectomy, do you still have Hashimoto's after surgery?
Great question. So
I just got asked that yesterday, or my last clinic.
Yeah. Well, we get this question a lot, even people without cancer, right? Who have hypothyroidism, they're on thyroid hormone replacement and they don't feel well. And they're often told by primary care providers that it's the Hashimoto's, or by other providers that it must be your Hashimoto's. And so the way I answer it is that Hashimoto's is an autoimmune condition. You have high antibodies and it can destroy the thyroid. It leads to inflammation and destruction. And then symptoms come usually when the TSH is high. So once we put a patient on replacement, then that whether you have a thyroid or don't have a thyroid anymore, then the Hashimoto's is less relevant because we've replaced you with thyroid hormone replacement. Now that might not fix all of the symptoms, unfortunately, because there might be a lot of different reasons for somebody having symptoms such as fatigue or brain fog or weight changes.
Lori, a few questions in here about REI refractory and the VEGF multikinase inhibitors and managing side effects both, proactively, and how does that actually work in your clinic to keep people on these meds?
Well, so that's kind of a very broad area, but I tell you that it's something that we wrestle with every single day in our patients on these therapies, because the therapies do cause frequent adverse events that impact on how people feel. I think it takes a village. So we have wonderful nurse practitioners, practice nurses. We work very closely with our dietitians because diarrhea and weight loss is a frequent side effect of the therapies. Hypertension can be seen. So we have a wonderful cardio-oncology team that helps us manage hypertension when when we can't just simply start, say, an ACE inhibitor and then the hypertension is well controlled. But I think that and then dose holds and dose reductions are part of the process of patients being on these therapies, and that we need to do that sometimes. One thing that we've learned is that longer that people are off of a drug like lenvatinib, you can have impact on the efficacy. We try to keep dose holds to a shorter period of time rather than a longer period of time. We've learned a lot about how to optimally manage patients on these therapies over the years, and just need to put that into action as best we can.
Carrie, there's a question on here about what do they have to watch out for when you've taken out, I mean, sometimes you guys take out 50, 60, 70, 80 lymph nodes. Are they going to get edema? I mean, breast cancer would be a different story. What's the story there in the neck?
Yeah, so we all have thousands of lymph nodes all over our bodies. One question I ask is, don't I need those lymph nodes for if I get strep throat? And the question is, there are other lymph nodes that will clear that out. And in particular, especially medullary thyroid cancer patients, for some reason, just have a ton of lymph node metastasis, and sometimes really far back. We call this level 5, back near the lat back here. And so, yes, you can sometimes, hopefully you get that many. That means your surgeon did a very good job. But what happens to that space, it's ironic. You think it's going to be a huge, I mean, we used to, back in the day, the reason it's called a modified radical neck dissection is we used to take the muscle that's out front here, the vein that's in there, the internal jugular vein, sometimes the spinal accessory nerve. So it was a lot more sort of deforming. It looked like something happened. Most people who have neck dissections, even when you remove all of 50 lymph nodes, it really doesn't, beyond having a small scar there, it really looks the same as the contralateral neck. And it's primarily because it's covered by this nice, big, hefty muscle on top.
Can I just add that it also doesn't impact on the immune system. So the lymph nodes are part of the immune system for sure, but we've got hundreds of lymph nodes all over our bodies. So there's no impact that we see at all on the immune system.
Yeah, that's critical questions. As long as we're talking about lymph nodes, Mabel, question is, are there certain lymph nodes area that are more commonly targeted by papillary than others? Is like their usual places we look? What are the common things?
Yeah, so in radiology, we commonly get a nice cartoon, which is a drawing of the neck and the compartments with level 6. So we talk about that's the central compartment. That's where we commonly see lymph node spread. And then out lateral, we talk about the lateral neck, and that's usually levels 2, 3, 4, and sometimes level 5, as Carrie said. It's usually what we call ipsilateral. So if the primary tumor was right-sided, it tends to be lymph nodes on the same side, but that can be different in more advanced disease or in bigger tumors. So it's usually the same side, but sometimes can cross over.
Carrie, there's a couple of questions in here about papillary thyroid cancers transitioning to anaplastic, or how often does that happen? Is that something we should worry about?
Gosh, you're asking me? I feel flattered. You're asking the surgeon.
There you go.
I don't know. So interrupt me, Lori, if I screw this answer up. So, excuse me.
Got your back.
So there are certain, it is not thought, and in my opinion as well, I did do a couple of years of basic science, that benign thyroid nodules turn into cancers. I get asked that question a lot, right? So many more benign thyroid nodules than cancerous nodules in the thyroid. Then the question is whether or not you have a sort of well-differentiated or follicular drive. Remember, we have 2 different cells within the thyroid, the follicular cell, which makes up those little follicles, and then you have the parafollicular cells, which are unfortunately the ones that can turn into medullary thyroid carcinoma. So there's different cell origin. Within the follicular cell origin, we have what's common, we commonly have follicular, papillary, and now Herthal cell is a separate category within that umbrella. And the thought is that the either papillary and maybe Herthal cell as well, I know, can differentiate into poorly differentiated and anaplastic from the well-differentiated tumor. So you can see, I have seen, got very lucky one time, had a big papillary, and there was just a little tiny focus of ATC within the papillary, which sort of, which we got lucky, which meant we got it out before it became a problem. Did I answer that okay?
You did perfect. Yeah.
Okay,
what do I know? I don't know the answer to that. Okay, let's do this. We got about 3 minutes left.
I just want to add one more thing. It is, however, exceedingly rare of a phenomenon. It's hard, I think, to know. I think it does tend to be seen in more advanced papillary thyroid cancers, more bulky disease, and or more aggressive subtypes of papillary thyroid cancers. But nonetheless, even in those cancers, it's an extremely rare phenomenon.
Yeah, thank you for making that point. Very, very rare.
Okay, in our last 2 minutes, I'm going to go around. I'm going to give each of you about 10 seconds to tell me your last take-home message, and then we're going to turn this back over to Patty and Anjali. Let's always start with the most important ones. Lori, always go with the oncologist.
Oh gosh, I just have to say that this has been the best session with the best audience ever. You guys have asked great questions. And if we did not win the contest for the most questions answered, I don't know what's wrong with this world. Thank you, everybody. You guys are great.
Dr. Lubitz.
I have to say my take-home point is that every time I do one of these panels, I learn probably just as much or more than the audience members. And I want to let the survivors know that we learn just as much from them and it's a privilege taking care of you.
Absolutely. Mabel?
Yeah, and I would say it's such a privilege. We often go to a lot of talks and conferences, and it's with providers and physicians and scientists, but this was such a treat to be able to speak to patients and really practical questions and really questions at the bedside of what we face and what we do every day. So this is for us, it's actually a very natural audience as well and a very natural conversation, and I really enjoy it. It's such a treat.
Yeah, and this conference early on in my career taught me how to say I don't know, because you guys ask me questions I can't answer every time. So I'll turn it back over to Angela or Patty. You guys can finish this out.
Thank you so much. It was like the speed round. I mean, you went through over 100 questions. And I know we didn't get to all of them, but so much information for all of us to think about. Don't worry if you didn't catch it all. The session was recorded and it will be available live on the session list. I know a lot of you are asking, like, where do we find that? It is right where you were looking before. It's on the session list. I wanted to thank all of our doctors that are joining us here on this panel and over the weekend, as well as one teeny question I have is, when are the new guidelines coming out? I know you guys were talking about it, but I know it hasn't been finished yet. So, is there a release date?
In the future, as far as I know, I don't think
it's not in 2021.
No, it's not. It's in.
Okay.
So let's just say there's not. Actually, I don't know because I'm not on it this time. But I don't think there's a set release date. They're working on it. I know.
Okay, good to know. Good to know. And I want to say thank you to Gary Bloom and Teresa. Just for all of their hard work, and this wouldn't be possible without that. All of these sessions had session producers who were behind the scenes, and Jackson is our session producer for this particular one. Thank you so much for keeping all of us connected and all the technology you've been working on all weekend. I appreciate that. Chat is just exploding with positive comments, and thank you so much to everyone. Have a wonderful Sunday.